Good morning, good afternoon, and good evening. A very warm welcome on behalf of the IAPB events team. We're very much looking forward to supporting you with today's Focus on Glaucoma webinar, a Glaucoma Toolkit for Africa.
Hello, everyone. Good afternoon, or perhaps good morning, wherever you are. I'm delighted to have you here today. It's really exciting that IAPB is taking up this launching of the Glaucoma Toolkit. Just a quick one. In June 2018, I got an email from Jess of Light for the World asking for a collaboration for glaucoma program in the 3 countries that they would be working on. And that conversation started on a bus ride. And it's several years now, the idea has morphed into a toolkit for glaucoma management in Africa. Wow, we really greatly appreciate the initiative by Light for the World to take this up and to ensure the development of and completion actually of the toolkit, because you know how it is, so many things happen and we finally completed it. So this is really great. And today it's really a beautiful story of collaboration for a common purpose, the prevention of blindness from the silent blinding eye disease glaucoma. So you can imagine how many collaborators we have, and we'll be speaking to some of them today. The aim of this webinar is knowledge transmission. We would like you to know about the Glaucoma Toolkit in Africa, raise awareness, and promote the dissemination of the toolkit so that we are able to use it. And it's not just for eye doctors, it's for the glaucoma care team. So the participants today comprise of eye health, human resources, and stakeholders in eye health in Africa. And we even have some invitees on the audience from WHO, Friends of Eye Health from our respective countries in Africa, etc, etc. It's fantastic to have everyone here and you're welcome. We'll be discussing certain aspects of the toolkit. And today, can I call on Dr. Mohammed Abdul, and he will tell us a little bit about himself and tell us why he's here today. Thank you.
Hello, good afternoon. I'm Dr. Abdul Ahmadi of Abubakar Tafawa Balewa University Teaching Hospital in Bauchi, Nigeria. I'm so honored to be here and grateful to represent the Faculty of Ophthalmology of the West African College of Surgeons and to have participated in the production of this vital document, a toolkit for glaucoma management in Sub-Saharan Africa. The time and effort all participants have given ensures that ophthalmologists in training, and even glaucoma specialists will have access to the effective tool along with all the resources that it contains. I want to thank IAPB, Light for the World, Sightsavers International, COECSA, SAFO, International Council of Ophthalmology, and many others for enabling the sharing of knowledge and skills through this document and for being incredibly supportive. You understood what we needed and what we were trying to achieve, and you helped make it possible. Your generous grants of funds, time, and resources are deeply appreciated. I would also like to take a moment to thank Dr. Fatima Kyari for effective leadership in the production of the document. It is difficult in this brief moment actually to acknowledge everyone, but I'm happy to, but it's wonderful to have everybody on board. Now, the objective of the West African College of Surgeons is the promotion, organization, and conduct of postgraduate training in surgery in West Africa. And so I'm confident that the faculty will incorporate the document into the training module for residents in ophthalmology once the final version has been endorsed by the college. And I also spoke with the faculty chair who said it will give general aspects of what knowledge or skills to acquire. And he thinks that the toolkit provides a lot of these skills and knowledge. He also said that it will facilitate training, that the toolkit will provide resources for contextual training of the glaucoma specialists and general ophthalmologists in our sub-region. It will also be an indispensable tool in the provision of care to our large pool of patients as it provides a practical guide to diagnosis and individualized treatment for glaucoma. We therefore urge everyone in the faculty to take time to study and effort to practicalize the tips for management of glaucoma outlined therein. Finally, I pray that this tool, officially known as a toolkit for glaucoma management in Sub-Saharan Africa, will achieve all its set objectives in the management of glaucoma and helping to eliminate or at least reduce the incidence and prevalence of avoidable blindness from this dreaded but fortunately manageable disease. Thank you from the West African College of Surgeons. Thank you.
Thank you very much, Dr. Mohammed Abdul. I think Dr. Dan Kiage is here. You're welcome, sir.
Yeah, thank you, Fatma, and thank you everyone who is here. Thank you for inviting me. My name is Dr. Dan Kiage. I'm an ophthalmologist and a glaucoma specialist, and I work in Kisii, Kenya. And I also chair the glaucoma community of practice for COECSA. I'm quite glad that finally the toolkit is available. We should thank Fatma Kari and all those who participated, who contributed, who supported in one way or another to having this toolkit available for use. It's a very unique tool, and it complements the guidelines we have. I know we have guidelines from ICO, from COECSA, from other regions. So it's actually complementary to all that, but it has some unique aspects in the way it's been created, on that it's going to be much more practical than the other things that I've seen around. And the really work is really ahead of us. We have to place this toolkit in the hands, the minds, and the hearts of the users. Speaking from COECSA, I'll urge the glaucoma specialists and the senior ophthalmologists to take lead and work with the leaders of hospitals, of Ministry of Health, of the NGOs, of the ophthalmic industry to make this happen. And they especially urge the point of users, the clinics, to use this document to create SOPs and to use it for training, and to use it especially as assessment charts in glaucoma. I know glaucoma is a challenging disease, and most people, the treatment, the diagnosis is quite challenging. But when you have a toolkit like this, I'll equate it to like the kind of SOPs that maybe the aeroplane crews have, that they repeat so many times and they use it so many times that it becomes safe, you know, to fly a plane from one point to another without many crashes happening. So if we can use this toolkit, and I'll urge the people who are spearheading this to also abate it in a way that it can be downloaded and used, and then personalized by those clinics and hospital concerned, and be used so that those charts don't remain in that document, but become part and parcel of what the clinics are going to have. So I urge my colleagues in the region from COECSA to go through it and listen to the introduction, and we sure that going to the future, glaucoma will not be handled the same like we are handling now, but will move a step forward. Thank you very much.
Thank you, Dan. Now I'd like to call on Professor Komi Balo. He's representing SAFO, the Society of Ophthalmology of Francophone Africa.
Thank you, Dr. Fatima. Dear panelists, distinguished guests, I'm Komi Balo from Togo, past president of African Francophone Society of Ophthalmology, called SAFO. I'm very honored to be part of this exercise. I was a participant of the session held in Addis Ababa with the invitation of Light of the World. Myself and two other colleagues from Francophone countries, namely Dr. Jeremy Agré from Côte d'Ivoire and Jérôme Sanou from Burkina Faso. That was in 2019 in Addis Ababa. I must confess that though I was not very reactive because of language barrier throughout the process, this process was very inclusive. And I can say that all voices were heard and taken on board. This final toolkit will be very useful for everyone. And as a representative of SAFO, I can see that the French version is awaited and will greatly help a wider dissemination in our linguistic zone. Just a few words in French for my SAFO colleagues, because I know that a lot of them are with us with this exercise. Je voudrais donc m'adresser à mes collègues francophones. Ce document est un outil d'une grande valeur pour nous, à l'instar des guides de l'European Glaucoma Society, que nous citons très souvent pour nos papiers et pour nos enseignements. Ce document, ce toolkit est conçu par des Africains et pour des Africains. Et donc, nous allons l'utiliser parce que c'est un document qui est adapté à notre région. La version française sortira bientôt. Et je crois que le prochain pays pour la dissémination, ce sera le Burkina Faso. Et donc, cette version française sera disséminée, et je l'espère, avec l'appui de l'ONG Light for the World. Dès à présent, il faut que nous nous approprions de ce guide pour notre pratique et pour nos différentes formations. Before I hand over, permit me to thank once again Dr. Fatima Kiari for this wonderful work done. Our SAFO ophthalmologists would like to tell you a grand merci beaucoup, Dr. Fatima. Thank you. Merci. That's all.
Thank you. Thank you, Professor Ballo. Really, I value teamwork a lot, and I actually blush when you keep calling my name. So let's look at it as a whole team, and it's really amazing what the team has produced. And thank you very much for talking in French to the French. It's also interesting to let you know that ab initio, we planned to have translations in both French and Portuguese. Yeah. And you remember we have a working group for that. So the translations are in process, and that's really great. So I'd like to call on Dr. Aaron Magava. He's the IAPB chair for Africa, and we're so pleased to have you here, Aaron.
Thank you very much, Fatima. I'm greatly honored to be part of this process, part of setting up of launching of toolkit, which is very important for our region as Africa. I am the IAPB chair for the Sub-Saharan African region. IAPB is an alliance of the global health sector, which has got over 150 members. And you know, some of the workers of the members are actually very active in this part of the world, such that this webinar is being hosted by IAPB Sub-Saharan Africa with partnership from Light for the World and Site Savers, who we have to thank, you know, for actually supporting this process from the beginning to this point where we are having this special event. We would like to thank also the members in the region who participated in the process, which was led, like everybody has been saying, by Fatima, a good friend of mine, through her hard work. And that teamwork produced this very important document, which is going to form a roadmap for the region to actually set up proper glaucoma services, which is something which has been lacking in most parts of our region. As you know, glaucoma affects the people of color more than the other races. So it is very important for us to be able to deal with it effectively, because vision plays a role in everybody's lives, you know, because you can't do anything without that sense in terms of working, going to school, as well as aging, in a respectable way, whereby you don't get injuries from not seeing where you're going. So this is going to go a long way in actually helping the people in our region. So thank you very much for all the people who made this possible. Without further ado, I am actually going to introduce our next speaker. So our next speaker from Light for the World is Dr. Jeffrey Walulembo. Jeffrey is an eye health expert. He's a senior ophthalmologist with a lot of experience in pediatric ophthalmology. He's involved in human resources development, community work, as well as policy and planning in parts of the subcontinent. He has been recognized for his good work by a number of world bodies, and he's also closely related, to setting up of services in other continents as well. Here I'm talking about setting up in Papua New Guinea. He set up, a pediatric retinoblastoma, premature retinopathy of true maturity services planning, which he did in conjunction with CBM and UNICEF. Dr. Geoffrey, welcome.
Yeah, thank you very much, Dr. Magavi, and thank you, IAPB, for organizing this event. On the part of Light for the World, this is a celebration because Light for the World is an international disability and development organization whose vision is an inclusive society where no one is left behind. We strive for accessible eye care services and support inclusive education, empowering persons with disabilities to participate equally in society. And as we launch the Glaucoma Toolkit, I was reminded of a story of a colleague, an obstetrician, who was carrying out a cesarean section. Then blood splashed on one of his spectacle lenses. He suddenly discovered that he could not see out of the other eye. And following that, an eye examination revealed he had advanced glaucoma with one eye already blind. And what we learned from this story, we learned that glaucoma affects people from all walks of life. Many have it and are not aware. And it has capacity to blind one eye undetected. And as we share more ideas on glaucoma, it's good to highlight some of the challenges, which include that for the glaucoma patients, sometimes there's no dramatic or any change at all in vision after they've had glaucoma surgery. And then for some of them, vision may drop post-surgery, in which case sometimes the motivation to accept that type, to accept treatment needs to be handled in a different way. And also, sometimes we find that we have to tell some individuals with glaucoma that a surgery may not be offered because may not be offered even though they have visual impairment, like some of the very advanced cases. Yeah, and then we also, from our part, we have some limitations because faced with a busy eye camp, usually there's prioritization given to people with severe visual impairment, mostly the cataract patients. But in the process, we sometimes miss the early glaucoma cases. Now, in our program countries like Mozambique, one of the surveys revealed that 23.4% of blindness was due to glaucoma. And in one of the annual reports of 2018, out of 8,000 suspected glaucoma cases, only 282 could access surgery and receive surgery. And then there have been challenges of consistency in supply of glaucoma drugs. So behind these statistics, we know that there are family members. We also sometimes may suffer from glaucoma. So glaucoma deserves more attention and more investment. So as Light for the World, looking at all these challenges, what did we do? Light for the World took up the challenge to find resources to address the glaucoma problem in Sub-Saharan Africa in a more affirmative way. And success with regard to getting resources came through one main donor, the Ellis Krona Fresnius Stiftung Foundation. And we would like to acknowledge them and to thank them. So Light for the World launched its first multi-country glaucoma program called Addressing Challenges of Glaucoma, the Silent Thief of Sight, aiming to improve glaucoma services in Burkina Faso, Mozambique, and Ethiopia at the end of 2018. And then through discussions, as has already been alluded to by Dr. Fatima, it was possible to bring together a group of experts and general ophthalmologists to bring them together for a workshop in Addis Ababa, which was hosted by the Ethiopian Society of Ophthalmology. And we'd like to thank them for that and acknowledge them to develop a practical toolkit for glaucoma management in Sub-Saharan Africa. So initially, it looked like perhaps it required translation and adaptation of the ICO guidelines. But then the context of many of the glaucoma patients we deal with in Africa had to be factored in. So it became clear that a more comprehensive tool was needed. And we want to thank the lead consultant who was engaged by Light for the World, Dr. Fatima Chari, for leading this process and bringing about what we are describing today as the Glaucoma Toolkit, which is a compilation of practical steps towards diagnosis of glaucoma, risk assessment for progression, and management decisions, as well as specific guidance for treatment and referral to key resources. Some of the highlights of the toolkit include models of service delivery and financing of glaucoma care, monitoring and evaluation, advocacy and raising awareness, equipment lists for a glaucoma service, research development and innovation for glaucoma services. So what is next? Translation into French and Portuguese is already ongoing, and this will be finalized in the next couple of weeks. And then proofreading, even the English version, most of it is already done, but there could still be areas that may need attention. And then piloting of the toolkit in Nigeria and Ethiopia, which is also ongoing. And then this is going to be followed by national launches of the toolkit to disseminate, advocate, and ensure ownership of this very important document. So the national launches being organized by Light for the World will be in Burkina Faso, Mozambique, and Ethiopia. I would like to thank you for your attention and thank all those who participated in the development of this toolkit, because I know that together we can defeat the silent thief of sight. Join us. Thank you.
Thank you very much, Dr. Jeffrey. It's very exciting. I mean, as I mentioned earlier, it's a it's a teamwork. And you can see that we had so many other people who are not on the panel today that have contributed to this enormous piece of work. We have the Elskrona Fresnier Stiftung, which is from Germany, sponsoring most of the work. And then, of course, we had the guidance and, you know, the heading of the International Council of Ophthalmology as well. And members of the Royal College of Ophthalmology were also on our team when we started. And the members of the Africa Glaucoma Network as well. So it's really a whole teamwork. And because of the segments, we had so many segments, up to about 10, 11 chapters in the toolkit. We are going to be discussing just a little bit to give you a taste of what it is. And I would like to call on Dr. Adunola Ogunro. She's going to focus on the training and the capacity development of which she led for piloting the toolkit at the University of Abuja Teaching Hospital. Dr. Adunola Ogunro, please.
Hello, everyone. I want to thank Dr. Kiari for the excellent coordination of this project. And I'd like to thank the Sight Savers country coordinator for the invitation to pilot of this project as well. Also, I'd like to thank the head of department of the University of Abuja Teaching Hospital and his team for their cooperation. The objectives are to enhance the clinical skills for diagnosis of glaucoma among the ophthalmologists at the University of Abuja Teaching Hospital, and to provide support for surgical skill improvements in glaucoma surgeries. Next slide, please. The syllabus incorporates modules, 6 modules, which comprise of the gonioscopy and objective assessment of optic nerve and OCT perimetry. The third module was medical treatment and formative assessment, surgical treatment, laser treatment, and surgeries as the 6th module. And for each module, there were learning outcomes which every participant is supposed to achieve. Next slide, please. The syllabus is knowledge-based, knowing about the surgical anatomy of the limbus trabecular meshwork, the anatomy of the visual pathway, pathophysiology of the aqueous outflow, and differential diagnosis of glaucoma. Next slide, please. In terms of the improvement of clinical skills, taking the good history with attention to risk factors in primary open angle glaucoma, to do slit lamp examination, gonioscopy, optic nerve head, and retinal nerve fiber examination, diagnosis of glaucoma and the type of glaucoma, referring to the Glaucoma Toolkit for glaucoma diagnosis algorithm, and be able to make choice of treatment, discuss with patients and relatives with the options, and be able to follow up patients at the choice of treatment, and perform pre-op assessments, carry out safe trabeculectomy, and manage post-operative complications. Next slide, please. The surgical skill improvement is tailored towards performing safe trabeculectomy with or without releasable sutures, with soft skills in the choice of instruments and sutures for every stage of trabeculectomy. Next, please. And in assessments of the individual trainee, this is competence-based and feedbacks gotten from the trainees. Next, please. The method of teaching, we included the lecture-based learning and self-directed learning, direct observation, of procedural skills and virtual case-based learning. This picture shows one of the trainees at surgery and also post-operative assessment of one of the patients, first day post-op. Next slide, please. And the training is based on DEAL concepts, which is dialogic, experiential, and active learning, which is a cyclical process whereby the topic is selected and the research study is done and different approaches are taken into considerations, and then the best approach is refined. The next, please. This concept tries to engage in dialogue to determine the focus of learning and build your experience in teaching. It also helps an individual to enter into active self-learning and directed on the process. Next. So the training with DEAL helps to focus on excellent performance and results as a trainer and an educator. Next. Next slide, please. So in summary, the training is based on best practice pattern using the Sub-Saharan Glaucoma Toolkit, creating boundary but not bounded, rethinking glaucoma with diverse range of diagnosis through gonioscopy, diverse range of treatment through human development and learning, and it helps to unleash the potential by research, creativity, participation, and collaboration and learning, leaving no one behind. Thank you.
Thank you very much, Dr. Adunola Ogoro, and we greatly appreciate the head of department of ophthalmology and the leadership of the University of Abuja Teaching Hospital for providing the avenue to do this, and all the trainers and the participants, and thank you to Keep Sight Initiative of the Sight Savers, which is sponsored by Allergan, who has actually propelled that pilot study at the University of Abuja Teaching Hospital. Again, I keep telling you, it's just a huge partnership, and everyone is involved for a common purpose, to prevent the blindness from the silent thief of sight, glaucoma. I'd like to call on Dr. Admasu Fiseha. He's from Gonda, Ethiopia. He's also a glaucoma specialist who is involved in piloting the toolkit, this time in a different way. And we thought to kind of adapt the diagonal system of referral and feedback of the LV Prasad Institute, which was introduced to us during the formative stages of the toolkit by Dr. Nikhil Chowdhury. So Dr. Fiseha.
Hello everyone, and thank you the organizers for having me. I'm Dr. Fiseha Admasu from University of Gondar in Ethiopia. University of Gondar is located on the northwest part of Ethiopia, close to Eritrea and Sudan border. That's where I work, and we are supported by Light for the for our clinical activities. So this toolkit, which has been produced by a group of ophthalmologists and other people from all over the world. I was also part of the toolkit preparation, and after seeing it at the end and trying to pilot it, I have noticed, a lot of, good things about the toolkit. My own takes include, the toolkit it's a brilliant document that provides clear direction for the management of glaucoma in a resource-limited setting. Though most studies done in glaucoma are out of Africa, the toolkit has come up with evidences to manage patients based on experiences in different centers of Sub-Saharan Africa. And the toolkit also provides important information for both glaucoma specialists and general ophthalmologists and other eye health workers to make a better decision in the management of glaucoma in Sub-Saharan Africa. And more important, unlike most other toolkits that we know of, that are prepared for Sub-Saharan Africa and case management guidelines, it does not have, a syndromic approach where you utilize one management plan for all types of disease condition. So this document help to make individualized decisions. This is very important, which is that glaucoma, even twice of the same patient may not be managed with the same treatment plan. So this toolkit has come up, with brilliant way of managing each patient, individually. So I like this part. I like this part a lot. And also, I found the algorithms, the pathways for decision making to be very helpful for training of my residents. I have already piloted it made presentation for the residents, and they are liking it, and sending them to reach diagnosis and come up with the management plan of their own. So our experience with the toolkit was first shared to all residents, staffs, and I made introductory presentation was made, and we are now using it, the forms, for filling up, both new and follow-up patients in our center. So the evaluation form, it captures detailed data on the patients, and it's user-friendly. Especially the first part can be the identification, the history part, the visual acuity, and the refraction can be filled by nurses or optometrists, and the rest can be filled by ophthalmologists. That saves a bit of time. Filling the form, the new form, in average, it took us around 5.5 minutes on the computer on soft copy, and around 4 minutes on the paper to fill in the forms. This is the forms. I think it's maybe presented by other presenters. This is the form that for new patients, and we are filling each form, for our new glaucoma patients. So it is a 2-page form, and it captures for both the history part and the physical detail part of the physical examination, and also the investigation, including visual field and OCT. So this is how we fill it. I'm not sure if it is displayed well, but this is how we fill it when we fill it manually. And it can be filled, the first part of the form, especially the identification, the age, and this area till the physical examination, it can be filled by the nurses. That will facilitate the timing of filling the form, so that the doctors can see a lot of patients as much as possible. So we have noticed, some shortcomings on the forms. One of it is, after seeing it on 10 consecutive patients, we have observed that there are some issues with the form. One is ethnicity. It could be very sensitive in some areas, including in countries like that of ours, where ethnicity is a really sensitive issue. People may not want to tell their ethnicity because, especially if they are a minority group, they may think that they may not be allowed proper medical care. So ethnicity is a bit sensitive in our country. We found it a little bit sensitive. The other thing is there are some issues with the form that I will show you in my next slide. One of the issues is on the medical history, these bullets with a circle, once you select one of them, then it is very difficult to unselect, and it does not allow to select more than one disease condition. For instance, a patient may have both hypertension and diabetes, but if you select hypertension, you can only select either hypertension or diabetes if you are working on a soft copy. So that makes it a little bit difficult. Then it needs to be reworked on this area. The other one is with the visual acuity. The visual acuity, it only takes visual acuity in numbers. Like patient may have maybe no light perception, maybe hand motion. There is no way to put that on the soft copy of the computer. So we suggest that some modification has to be made there. And also on the second page, there is what's called, after measuring the intraocular pressure in the new patient form, it says target pressure. So the target pressure, we believe that it should be part of the management plan, because this is a new patient form. Then we measure the pressure, then it says target pressure before we make the diagnosis. So the target pressure should, we believe that it should be placed somewhere on the bottom of the form. The other thing that we have noticed is on the diagnosis, it only puts glaucoma diagnosis. It does not allow you to put other diagnosis. Patient could be pseudophakic, the patient could be have AMD and other condition, and there is no slot to put other diagnosis on the form. These are minor corrections that need to be that can be made easily, but we strongly believe that this is really helpful, especially if you are planning to do research on the area of glaucoma. It really captures really detailed information about the patient, and it's user friendly, as I said, and both staffs and residents are liking it to fill in the forms. So I will also like to thank Dr. Fatima Kairi for organizing and coordinating the development of this toolkit, and thank you everyone for listening.
Thank you very much, Dr. Fiseha. Yes, as you all know, it's really a live document, and we wanted to subject it to that rigorous critique. And I have other information and feedback from others as well, which we are all considering, so that we can keep making it better and better and better. So it's like a live document, just like everything in the practice of medicine. So we welcome any observations and critique for the toolkit. I would like to call on Dr. Abdullahi Sadiq Mohammed now, and he will be telling us a bit. Okay, we have several chapters of the toolkit, and one of the chapters is the pathways or decision algorithm. This toolkit is actually supposed to be an aid to the glaucoma practitioner. So one of the things we did was to pick some really common types of glaucoma and have an algorithm for it. So I'd like Dr. Abdullahi Sadiq to tell us a little bit about the angle closure glaucoma algorithm.
My mentor pledged to be part of the team that produced this document. And it's really a very important armamentarium to glaucoma specialist, a toolkit in the management of chronic angle closure glaucoma. Can we have the next slide? Actually, we commonly misdiagnose, and most people believe we don't have chronic angle closure glaucoma, but we usually have it. And in the event that people are diagnosing it, and the event that it's diagnosed, it is commonly inadequately treated. So the guidelines, the toolkit provides important guidelines for the management of the disease. Now, this is generally initial, this is the journey of glaucoma patients according to the toolkit. So we start with the initial glaucoma patient's evaluation, staging of the disease, assess the risks of the disease progression before you plan the treatment, and then the follow-up visit. The initial part has already, PCR is there in, that's the initial point where all the information about the patient is taken care of, and then the diagnosis of the glaucoma is made. Then you stage the disease. PSCG is like pure AG. You need to stage the disease and know the extent of the disease at the time of the presentation. And also, next slide. So now after you have done that, then the next thing is the management plan. You now counsel the patient about the disease the patient is having, and then you have various treatment options. Next slide. Now, there are laser peripheral iridotomy is the primary treatment in patients with primary angle closure glaucoma. However, in patients that have plateau iris or plateau iris syndrome, laser iridotomy is the of choice. But some patients that have painful blind eye with very high pressure can actually use cyclophotocoagulations in the treatment of that eye. Next slide. Now, after the laser PI, after a patient had successful laser PI and the pressure dropped to less than 30, and they assess the, remember I said in the initial stage, you have to stage the disease. And of course, this you must have done some investigation like visual field and then assess the risks of the disease progression. Now, for somebody that has IOP of less than 30 and is early damage, you can commence the patients of medication. Because after laser PI, you do gonioscopy. If the angle is up in the treatment, it becomes like POAG. So IOP of less than 30, early damage, you can start the patients on the algorithm that's contained in the documents. Then sometimes you can also use medication to lower intraocular pressure in preparation for surgery. Somebody comes with a very high pressure or acute angle closure glaucoma. The first thing you do is lower the pressure, control inflammations, control pain, and then prepare the patient for surgery. Actually, what this part of the document is telling you is telling us the role of the medical therapy in the management of primary angle closure glaucoma. And then sometime after the laser PI or surgery, the pressure may not be to the limits that a clinician wants it to be. So in that case, laser PI, use of medication can also be employed to further reduce the intraocular pressure. Next slide. Yeah, next slide. Now, most of the time, primary angle closure glaucoma is a surgery still end up in the theater. So one of the treatment modality of primary angle closure glaucoma is lens extractions. Of course, we see the evidence from the EAGLE study that shows that clear lens extractions is more beneficial compared to laser PI patient with mild to moderate primary angle closure glaucoma. Lens extraction, lens cataract surgery, with trabeculectomy, and this has also been shown to show a good result. And then you can have glaucoma drainage devices if one of these after lens extraction, not at the acceptable limit by the clinician. Actually,
we do seem to be having some technical difficulties with the sound here.
Next slide.
Okay, I'll just let you keep going for a little bit longer and then we'll see. Okay, thank you.
The follow-up now. Now the follow-up depends. If glaucoma is stable, target of pressure has been reached, optic nerve rate is stable. Toolkit for glaucoma management is a welcome development, and it's actually streamlined treatments of glaucoma patients. And for me, it's a game changer when it is strictly followed. Thank you.
Thank you very much, Dr. Abdullahi Sadiq Mohammed. I know we had a few challenges with streaming, but we really got all you were saying. And I would like to call on Dr. Philip Fatudi. He is from South Africa and was representing the International Council of Ophthalmology at the time of the development of the toolkit. And Dr. Philip Fatudi, I know you led the chapter 4, practical procedures and the recipes. Out of the millions and hundreds of recipes that were available for us to use, first of all, you tell us why we decided to use recipes rather than writing out our own, just signposting where things have already been done. And secondly, how did you manage, you and your team, how you managed to choose which ones to actually signpost? Dr. Philip Fatudi.
Thank you very much, Dr. Kiari. As mentioned, the aim of this section is really to signpost the useful resources such as online articles and videos. And we refer to existing guidelines and where appropriate have adapted them to be fitting to our working context. The layout is designed to be an easy to follow and read and not too long. It contains a basic description of the procedure, followed by references to websites and online material for further information. If one is reading the electronic version of the book especially, the idea is to click on the referenced URL or the reference, and it will then direct you immediately to the source of the document or video, where more information can then be obtained. It is also important to mention at this point that this list is in no way an exhaustive, complete list of all procedures in glaucoma, but we have selected those that we hope will bring value in the Sub-Saharan African context. And just a brief overview, there are 4 subsections. The first one being examination and diagnostic procedures. And here we highlight the important aspects of diagnostic procedures using glaucoma management, such as intraocular pressure management, for instance, performing gonioscopy, and optic nerve examination, amongst others. The second part is the glaucoma laser procedures. And SLT and other forms of laser have been shown to be invaluable, cost-effective tools that can definitely be used in our context, where follow-up of patients can be a problem. And the third section was the surgical procedures. And glaucoma in Sub-Saharan Africa, as we know, is a much more prevalent disease compared to other population groups, and present at a more advanced stage as well. And therefore, it is almost impossible to talk about glaucoma management and not mention penetrating glaucoma surgery such as trabeculectomy with antimetabolite usage. And these guidelines on surgery are also in no way prescriptive. As we know, there are many variations that can be adapted to suit your population and resources. We also look briefly at non-penetrating glaucoma surgeries, as well as glaucoma drainage devices in the chapter. The fourth and the last contribution is minimal invasive glaucoma surgery or MIGS. And even though cost is always of great concern in our context, we found it pertinent to mention these newer treatment modalities, as most, if not all, can be used in conjunction with cataract surgery, and therefore should be kept in mind when looking for surgical options. And we really hope that this section will be of great benefit to those using it. Thank you, Dr. Chiari.
Thank you, Dr. Philip Fatudi. That's just threw a little bit of light on why we used the signposting for the procedures. And I would like to call back on Dr. Aaron.
Thank you very much, Fatima. And thank you very much, Philip and Abdullahi, for the presentation you have just made. I'm going to call upon our next speakers. This is going to be a co-presentation between Kola and Serban. Dr. Kola Ogdimo is a senior global technical lead at Sightsavers. Dr. Serban Penzin is also with Sightsavers, based at the country office in Kaduna, Nigeria. They are here to look at the public health aspect of glaucoma, look at the experiences in India and Nigeria, as well as talking about the issues we get in management in terms of the social aspects and the behavioral aspects which affect our management. Thank you very much, Kola and Serban.
Thank you, and thanks to everybody for the brilliant presentation so far. And just to start off by highlighting that this is a very collaborative process as it has unfolded. And it actually also comes out of some work that has been done previously with IAPB and many partners from Accra and Uganda, where we actually began to formulate the thoughts of long-term glaucoma activities. And here I'm just going to touch on, Serban and I are just going to touch briefly on briefly on the things that we are beginning to do in the collaboration with Allergan. And we also thank Allergan for supporting this piece of work. It's been an ongoing discussion since we first started discussing with them since 2011, following the Uganda conference that we had on glaucoma. So it's been a long road, but it's never too late to start. So next slide, please. So these hypotheses are that if we use the risk factors which we have collectively put together, starting from Uganda, that if we apply these risk factors, we should be able to lead to improved community uptake of screening and therefore earlier diagnosis and treatment. And I want to take us back to something Dr. Oguro said, which is leave no one behind. We will not really deal with glaucoma if we sit in our clinics alone. In fact, one of the scourges of the clinician, which we all talk about, is when we see these patients who are already blind or very close to being blind, completely blind in both eyes at its first point of contact with the health system, by which time it's too late. So the public health and the approach and the community approach is going to be important to actually achieve our objectives in glaucoma. And we've the other hypothesis has been mentioned around improvements of the management, so I won't talk much in that. And there are a number of assumptions we make, which is that communities will actually willingly participate and the improved health knowledge will help. And we also believe that there's a positive behavioral change will lead to improved uptake, but that is also an assumption. Next slide, please. So the pilot concept includes the hospital services, a trial of integrating glaucoma screening into community and primary eye health, and then exploring the social and behavior aspects of glaucoma and their effects on the uptake of services and the quality of care. Next slide, please. So we have two pilot sites, one in India, which started in September 2019 following agreements with Allergan in 2018. And we started the Nigeria pilot in January 2020. It will be obvious that this falls into COVID-19 and period, and it has been a major challenge to the clinicians, to the hospitals to actually get things done in this. And I really want to thank the team at UATH, including Fatima here, who is also part of the team, what they've been able to do under the circumstances. Next slide, please. So these are some of the key things that we're doing in terms of improving the quality. Next slide. So we are working with the Gwagwalada Area Council, in the Gwagwalada Area Council with UATH. And we also, for this community screening part, we selected a community near Gwagwalada called Dobi, with a population of approximately 20,000 people. Next. Now, the public health intervention includes some community mobilization and vision screening. So the community volunteers and health workers, and we could use whoever is available in the community. They are trained on risk factors and for screening on visual impairment. So they're not actually being trained clinically or specifically for glaucoma, but for the known risk factors for glaucoma, with the objective that if that becomes common knowledge, and we're testing this hypothesis that if that becomes common knowledge, you would actually have an improved uptake of real screening at the primary level or at the hospital, as the case may be. And then the patients for this pilot were referred to a prepared primary health center with a skilled eye health worker. Because of COVID-19, we did not use the direct ophthalmoscope, which is what the common instrument used, or use a fundus camera. Social distancing was maintained. Next slide, please. So these are photographs showing the training of the the volunteers for the community risk factor identification, and then the primary screening being done by the optometrist in the primary health center. Next slide, please. And the outcomes. Initially, we had good positive uptake, high response, but subsequently there was a decline in screening attendance, and investigation further showed that there were some unmet public expectations with incentives and some problems with the waiting times at the primary health center. Largely, we think because we were using a fundus camera, which was much slower in terms of actually capturing the images and reviewing them. So these are things we're definitely looking at in sharpening the messaging. Next slide, please. So, okay, sorry, just back for one moment. So I want to say that both in India and in Africa, in Nigeria, something that we really are seeing some very positive results. In India as well, we actually see that, I mean, for the India pilot, we actually had a well-experienced team with an established eye hospital, with established community screening, and with an actually well-established glaucoma unit. What they have seen is significant uptake of services following the community screening, early identification, and patients coming in and accepting the services more readily. That is very positive and gives us some initial feelers that actually a public health integration of glaucoma screening would be useful and positive and cost effective. It is early days yet, so we're not actually, we will publish figures when the pilots are complete. And then we'll look at also scaling up and testing these hypotheses more widely and testing out the methodologies that we have tested, we have used. So now I will hand over to Selben, who will talk about the related and very important social behavior aspects of glaucoma that we're also looking at, which will be integrated into the findings of which will be integrated into the program as we move forward. So then, over to you.
All right, thank you very much and good afternoon, everyone. I'll give a brief summary of the findings from our social and behavioral change aspects in glaucoma. The Keep Sight project started in October 2019, the pilot project, and one of our expected outcomes is to generate evidence and develop learnings that will further inform better strategies for longer term planning. As such, we conducted a formative analysis in the Gwagwalada area where we're working with key stakeholders on the project to understand the insights into the factors that influence the various behaviors into glaucoma uptake of services. And we did that because we wanted to get information or evidence that will help us develop and implement specific behavioral change strategies that improve positive attitudes towards screening, diagnosis, and long-term treatment compliance and therapy for glaucoma. And essentially, we wanted to identify the factors that enable or promote uptake of glaucoma services, and also the factors that prevent or barriers to uptake or positive health seeking as it relates to glaucoma. So we conducted focus group discussions and key informants interviews, and we mapped our responses into various conceptual frameworks. The first we used was to identify factors that influence the screening behaviors relating to screening and testing, that is pre-diagnosis. And we found that by far the strongest influence is motivation, which it could be at a personal level or at a community level. And it's essentially the processes that drive a person's rational decision-making process. And this was closely complemented by the capability of a person to make decisions about their health. And that is in terms of having the appropriate information and skills and knowledge about glaucoma and the disease process itself and the available treatment options and long-term planning for glaucoma. And then the opportunities that present themselves for a person to be screened, for instance, the availability of outreach services. But for us, we were very particular about having a primary screening site within that community. So that is an opportunity for people to have primary screening. And then after the post-screening or post-diagnosis and onto long-term treatment of glaucoma, the factors are essentially individualized. They are based on an individual's perception about the disease process. So the individual's acceptance or understanding of the gravity or depth of the disease and the severity as it relates to them as an individual, and then the benefits of a chosen line of treatment, that the benefits that it will have on the person, and then their own personal barriers to accessing health services, and then the actions that they take in terms of the environmental factors that prompt them to, as individuals, to attend regular follow-up appointments, and then their confidence in themselves to actually do something to prevent further sight loss. So these are some of the factors that we put into and mapped out our findings there. And then our recurring themes from all our interviews at the level of, at the community level or before diagnosis, the strongest influencer that enables people to accept to go for a screening is actually the desire to prevent blindness. In some people, it is appearance of a symptom, which we know that for glaucoma, that is actually a step ahead of advancement. And then other social elements like having a family member who has been previously diagnosed with glaucoma or who has gone blind, or having positive information or promptings from opinion leaders in the community. And then surprisingly, again, there were people again in the communities who felt that they were powerless to do anything about their vision loss, and they would actually allow nature take its course. So that was a strong barrier to positive behavior that we found in the community. And then at the level of diagnosis and long-term treatment, one of the strong enablers that we found was quality counseling that the patients received from the doctors. They were very particular about what information they got from the doctors and the empathy received from the doctors. And then, as we know that in Sub-Saharan Africa, in many of our settings, the options for treatment are either surgery or medical treatment. There are other options as well. But these two complement themselves in the sense that for some patients, the fear of surgery makes them opt for medical treatment, and the converse is for others. When they prefer a one-off treatment, they would rather go for surgery. But in both cases, both work at different levels to enable people adopt a positive behavior towards glaucoma treatment. And then the deterrents that we found were quite in line with the available literature and research in different areas of the country. The most bothersome is prohibitive cost of care and treatment for many people. And then the fear of surgery also for a lot of people who have the option of going for surgery and are not able to keep up, and because of the fear of surgery do not take up that option, and at the same time are not able to manage their condition because of the finances cost of care. Those are some of the barriers that we identified. And then the treatment longevity, again, it's another barrier because of the repeated use of eye drops several times a day over a long period of time. Some people may be prone to forgetfulness and a lot of things. These also reduce the compliance rate for medical treatment. And then largely, again, the lack of visible improvement. Generally, when people take medications for a particular condition, somewhat they expect that there's going to be some form of improvement. And since that is not really the case with glaucoma, it sort of dampens their enthusiasm to continue the treatment over a long period of time. And then generally, the environmental factors that support or deter people from taking up a positive attitude to glaucoma treatment, first of all, is, like I said again, quality of counseling and advice they receive from their doctors. And then the deterrence, specifically for the community where we work, where we conducted our interviews and the hospital, is largely for them the lack of empathy they feel from the doctors and the general bottlenecks they face in the hospital going back and forth. And then this is also related to the limited human resources available at the hospital, the tight schedule of doctors and a lot of work they have to do. We're making the patients spend long hours in the hospital waiting to see a doctor and losing productive time at their places of work. So, having documented all that we have learned from the formative analysis, our next steps want to, in the short term, complete all our activities for the initial pilots in the coming weeks, and then to document and review all our learnings, and then to develop and test our strategy, intervention strategies in the medium term, and then overall for us to develop cost-effective interventions that will enhance or integrate glaucoma care into general medical care. I would like to thank Allergan Pharmaceuticals for funding this KeepSide project for us, the pilot phase, and then the management of University of Abuja Teaching Hospital for the good partnerships we've enjoyed with them. I'd like to thank Professor Ayani, the head of department of the ophthalmology of the University of Abuja Teaching Hospital, who has led the process in the hospital, adopting all the toolkits, piloting and everything in the hospital. And then to especially thank Dr. Ogunro, who is a glaucoma specialist at the Eye Foundation Hospital, who has taken it upon herself to facilitate and lead all the modules and training and the mentorship for all the doctors on the project since its process started until date. Thank you very much.
While we wait, while we wait for Fatima, I'm sure she'll soon join us. Just to also say, acknowledge a few other people, our social and behavior change scientists, Kathy and Gerald, who made the inputs of their expertise in social and behavior change, which is not a skill set of us ophthalmologists, but so again, the complementary skills that are needed to actually achieve what our objectives in glaucoma. And again, to just to highlight that we do need to scale these things, these up, and it will be necessary for us to be engaging with community, with community screening, and an acceptable, cost-effective public health approach. Otherwise, we will not actually achieve our objectives. We'll just be scratching the surface if it's the clinical side alone that we face. The clinical side is extremely important. Without that working, is the bedrock. There's no point doing the screening. But with that working, we must do the screening, and we must get that right and proper.
Yes, Simon, I think Simon, if you could please post the questions, and then we can 3-4 questions.
Yes, certainly. We'll so, thank you, Aaron. So thank you to all of our listeners. We do have some interesting questions which have come through. Aaron, perhaps I can relay the questions, and I feel that the questions go out to some of the different speakers. So the first one, I think, since we've just heard from Kola and Selvin, is a query about the toolkit. Where are your plans to implement the toolkit next? So we understand that you've had the initial experiences, but which countries are you looking at next to implement the toolkit?
So Kola, if you could take up that question. So.
Or is that to us in Sightsavers?
Yes,
okay.
Yes.
I think I will answer that question in a two-pronged way. Mm-hmm. First of all, is that this is not a Life for the World or IAPB toolkit alone. It is a toolkit for Sub-Saharan Africa, and it has been launched in this. It is available for public use. You do not need to wait for a partner to begin to implement it. In fact, most of the toolkit is clinically based, and therefore will be a tool to enhance your practice in every level, whether you're a tertiary institution or a secondary institution or a public health oriented institution. So that's the first thing I would like to say. So please, wherever you are, take it, own it, and use it. It will help in your practice, even if you're a good specialist, to be honest with you. Now, on the specific question, which I think was being, which other countries are we going to roll it out? Again, therefore, it is not really the toolkit we would be saying we're rolling out. The toolkit is a toolkit for implementing the glaucoma. But if we're saying, are we going to roll out in other countries? We are currently in discussions about that. A lot of what we discussed is still, can we say, in the early stages. You'll notice that we deliberately did not publish figures because figures will change as the pilot progresses. I mean, we deliberately did not show figures, but these will be published in due course. So we will have to make, we still need to make the decision whether for us, this is the time to expand to further countries, or we need to get more experience within the same countries. One thing that is definitely not going to be the case is that we will not stick just one. These were the initial pilots, and we'll definitely look to scaling this up to some degree. But the actual decisions will follow the review of the learnings and will be guided by what we still need to learn. Yeah, thank you.
Thank you very much, Kola, for that. Simon, if you could read other questions and then we can direct them to the panelists.
Yes, certainly. So I think this question is for Jeffrey from Light for the World. We've had a lot of positive comments about the toolkit and a lot of enthusiasm for this toolkit. And an indication of this is a participant from another region. And their first question is, firstly, complimentary towards the toolkit, but then their question is, could this toolkit be used in other regions, or would it be possible to adapt this toolkit to other regions?
Yeah, thank you very much for that question. One of the main purposes of this Africa launch of the Glaucoma Toolkit is to make it widely known by the practitioners and other stakeholders in eye health for purposes of using it in the different parts of Sub-Saharan Africa. So the answer is yes. Thank you.
Thank you, Jeffrey, for your answer. Thank you very much.
I wanted actually to highlight Colors and Settlements talk, which is public health, and I'm sure this has already been highlighted. Very important part of the toolkit. The Keep Sight initiative has brought in a great big important dimension to the care of glaucoma patients. One last thing is Fred Hollows Foundation. I know when I started the study on glaucoma epidemiology, it was Fred Hollows Foundation that supported it many years ago. So thank you, Fred Hollows Foundation, for bringing glaucoma to light. And there's so many other people I would really not like to mention names, but as you know, I wear so many hats sometimes, and we were waiting for this toolkit to actually finalize and actualize. And from the International Center for Eye Health, we are developing the Glaucoma Clinical and Research Network for Africa. So I'd really like a lot, and it is a network that will look at both the clinical aspects, the community aspects, as well as the research aspects of glaucoma. And we will send out information as much as possible when after this webinar. So thank you very much, everybody, for being here. I'd like to hand over to Aaron.
I would like to thank everyone who's attended the webinar. It's through your support that we know that this toolkit is going to be used going forward. I would also like to thank the panelists who did a fantastic job. Not forgetting the sponsorship from Light for the World Sight Savers in Allegan, who have made this process possible. Would like to give them a big hand. Thank you very much, everybody.